Let us talk about another international patient safety goal: improve communication among caregivers. Effective communication reduces errors and improves patient safety. Communication can be electronic, verbal, or written. We have 3 patient care circumstances that can be critically impacted by poor communication. These are verbal and telephone orders, verbal and telephone communication of critical test results, and handover communications. Let us start with verbal or telephone orders. These orders should only be permitted when extremely necessary. Different accents, dialects, and pronunciations can make it difficult for the receiver to understand the order being given. Drug names and numbers that sound alike, background noise, and interruptions add to the problem. Transcribing a verbal order adds complexity and risk. Reporting back of critical results. Diagnostic tests include, but are not limited to, lab tests, radiology exams, nuclear medicine exams, and cardiac diagnostic studies, in addition to bedside tests such as point-of-care tests, portable radiographs, or transesophageal echocardiography. Results that are significantly outside the normal range may indicate a high risk or life-threatening condition. A formal reporting system reduces risk. Now, let us discuss handover communication. Healthcare providers usually endorse or communicate what happened to the patient during their shifts, to continue and complete what was not done within the shift, and to avoid repetition. Handover communication usually occur between healthcare practitioners and between different levels of care in the same hospital. For example, when a patient moved from the ICU to the general ward, and from inpatient unit to diagnostic or other treatment departments, and lastly, between staff and patient or families, such as at discharge. Breakdown in communication during any handover can result in adverse events. We could avoid all these problems by safe practices for effective communication. Healthcare organizations must develop a standardized process by which this information can be communicated consistently. Then train the staff and help support effective communication. Writing down, read back, and confirm. The doctor should sign the order within 24 hours or within the same shift if feasible. In this standardized process, the results of tests and diagnostic procedures should be defined. By whom and to whom critical results are reported, and the acceptable length of time between availability and reporting. Similarly, the results should be written down, read back, and confirmed. We should evaluate the timeliness of reporting. For handover communication, we have to use standardized critical content for communication by using a standardized method, forms, or tools to facilitate complete handover. We could use the SPAR technique, which means situation analysis, background information, assessment of the condition, and recommendations. All mentioned processes are applied to all caregivers, that's to say nurses and therapists, including physicians. When readback is not necessary, in ER or ICU during emergency situations. In this case, a nurse repeats back the order and another nurse lists down the order to be carried out immediately. Readback is not necessary also during physician-to-physician consultation and during dialogue between professionals or peers. Thank you.